how each of these are important. The goal of antimicrobial stewardship is more than just saying that you practice it. The goal of it is to optimize patient outcomes and decrease adverse events related to the use of antimicrobial therapy. Now let's talk about the elephant in the room. One of the challenges that we have in neonatology is that the babies we care for are fragile. And all of us have a low threshold for missing an infection. Infections can masquerade as many different things. And so because we view these babies as so fragile, our threshold for treating presumed infections is actually quite low when you think about how we might approach a child or an adult. So one of the most difficult things that we need to figure out, as I mentioned, is whether or not this is actually an infection. So I'll give you some examples of where it might be clearer and where it gets a little murky. So the first picture on my left is that of an elective cesarean section. There is no labor present, so there's really no reason to suspect that the membranes have had any translocation of bacteria. So I think most people would agree the risk of an infection in a baby who presents, let's say, with tachypnea after birth should be relatively low. But then we have an x-ray like the one on the right, an x-ray where there's haziness. People wonder, could this be pneumonia? Or could this be secondary, let's say, to a precipitous labor leading to transient tachypnea of the newborn? Many will ask, what is the risk of me not using antibiotics? How likely is infection? And we're going to talk about that soon. But then we've got other situations. You've got situations like where a baby is passing blood per rectum and you get an x-ray like the one that just was shown. In that situation, the probability that the patient has necrotized enterocolitis given that x-ray is quite high. And translocation of bacteria across the lumen and across the bowel wall is high. Therefore, most people would recommend antibiotic treatment, if not all. As mentioned, transient tachypnea of the newborn is a common problem that we have in the newborn intensive care unit. And it's one that's actually been looked at to determine what is the real risk of infection in babies who present with an x-ray like the one shown. This paper, which was by Dr. Weintraub back in 2013, examined 745 neonates who had radiographic transient tachypnea of the newborn. In this paper, none of 494 antibiotic naive infants and 212 of 251 antibiotic exposed infants had identifiable risk factors for sepsis. So in other words, the vast majority of patients in this study had an x-ray that was compatible with transient tachypnea of the newborn, but did not have risk factors for infection. Curiously, no infectious outcomes occurred in infants who did not receive antibiotics. Over 90% of the babies never received antibiotics and never had an infection. The message here is, in the absence of significant risk factors for infection, if you have an x-ray in a baby that is compatible with transient tachypnea of the newborn, the luck is on your side, if you will, that if you don't treat and you observe in hospital until resolution of symptoms, you are unlikely to put the infant at any significant risk of serious outcome. Over time, one of the things that doctors and nurses have liked to do is to try to predict or enhance the accuracy of detecting infection. There are so many different things that we have done. And in terms of trying to narrow down which patients are worthy of treatment, which patients are not, there are different tests. The CRP test, the procalcitonin has emerged in recent years. Looking at white counts and left shifts has been around for some time. Talking about the validity or the accuracy of these tests is beyond the scope of this talk, but I would ask you to look at your own hospital and what tests are available and critically examine what the current literature states as to the validity of these tests and the positive predictive values, sensitivities, specificities, and of course, negative predictive values of these tests. But one of the things that we always need to remember is that not all infections are caused by bacteria. One thing we know for sure, given that we've emerged from COVID, is that there's a whole lot of viruses out there. And just because a patient starts to deteriorate doesn't mean one should jump to the conclusion that, in fact, the problem is a bacterial one. So remember to broaden your differential, especially in the presence of negative cultures. As the saying goes, it's important to compare apples to apples and oranges to oranges. And back in 1988, the CDC, the Center for Disease Control, made a definition of what actually is a microbiological documented bloodstream infection. It requires one of the following. Number one, a recognized pathogen in the blood and a pathogen not related to an infection at another site. Example, a patient who presents with osteomyelitis, who has a secondary bacterial infection in the bloodstream, would be considered to have the primary being osteomyelitis. Number two, fever, chills, or hypotension, and any of the following. A common skin contaminant, such as the one that we recovered as coagulase negative staphylococcus. But please note, it should be on at least 2 blood cultures drawn on separate occasions. And the organism, again, is not related to infection that's already been documented at another site. Secondly, it could be a common skin contaminant in the presence of a patient who has an indwelling intravascular device. Lastly, it could be a positive antigen test in the blood, and the organism, again, is not related to an infection at another site. In the case that I presented to you, in which we only drew 1 blood culture, and that blood culture came back positive, according to the CDC, that would not be a microbiologically documented bloodstream infection because there was not an infection at another site, and we only had the 1 culture. So it could have been a contamination. Another common issue that we face is that in intubated patients who develop a new infiltrate on X-ray, people often jump to the conclusion that this could be a pneumonia. It could be a ventilator-associated pneumonia. That may be true, but just because a patient deteriorates, if their X-ray hasn't changed dramatically, or if an ultrasound assessment of their lungs has not changed dramatically, this may simply represent colonization if you've taken an endotracheal tube culture. Criteria that would be more in keeping with a true pneumonia or ventilator-associated pneumonia would be pathogens that are collected in the presence of a changing ultrasonographic picture or X-ray, along with a clinical deterioration such as increased oxygen requirement, temperature lability, hypotension, and so forth. As mentioned previously, it is so important to document a coagulase negative staphylococcal culture on 2 occasions because 1 culture could simply be contamination. And a paper that came out recently in 2024 highlights this. They looked at 139 culture episodes in 120 patients over 3.5 years. They defined a positive blood culture, that would be a true positive, as 2 coagulase negative staphylococcal positive cultures. A contaminant was 1 positive with 1 negative culture, and undefined was 1 positive and no further culture done, which would be sort of what I had done in the case. What they stated was that out of the 139 episodes of true positive bacteremia was identified in 44 of 139, or 31.7%. 30.2 and 38.1 were either actually negative or they were undefined. So only about 1/3 of these cultures that people would have sworn were positive were actually so. Now, one of the realities of working in neonatal intensive care is that our mind plays tricks with us. And how often have you been in the unit and someone has said, when the blood culture comes back and you question, could it be a contaminant? What you're told is, but you should have seen him. He was really sick. But when you think about that, that's a logical fallacy. The reason you did the culture is because they were sick. Certainly not every patient that you do a septic workup on has a 100% positive blood culture rate. So you need to remember that. We don't generally do blood cultures on patients that are not sick. If you need evidence of this, this is from a study which demonstrated, it's the same study looking at patients that had true bacterial infection, contamination, or undefined. And what you can see when you look at a comparison of the trues versus the contaminant or undefined is that such things that we seemingly associate with true bacterial infections, such as fever, hyperglycemia, hypoglycemia, increased apnea frequency, metabolic acidosis, a high CRP, a different level of white counts, platelet counts. None of these were statistically significantly different between groups. Increased oxygen demand, mind you, was, but it was in the group that had a contamination, not the ones with the true positives. One thing that was strongly associated in terms of differences was the presence of intravenous lines, like central lines, longer durations of lines, and being ventilated on the day of culture. But interestingly, again, for the ventilation on the day of culture, it was those patients who actually had contaminants that were more likely to be ventilated on the day. Therefore, it just goes to show you that just based on clinical patterns alone and things like increased apneas or increased oxygen, we shouldn't naturally assume that this means they have an infection. Another thing that I'm often reminded of is not doing the LP at your peril, meaning if you do an LP after you've already done the septic workup with blood cultures and started antibiotics, if you get a negative LP, it doesn't necessarily mean that you don't have meningitis. Low white cell counts may also be present at the time of the LP when antibiotics are already started in the presence of such organisms as GBS. So if you think a baby is septic, after the first few hours of life in particular, do a full septic workup. How we collect urine matters. In a study that looked at the collection of urine either by a suprapubic aspirate or via a urinary catheter, in 105 infants, what they found was there was a 71.1% false positive rate from catheter samples. So in terms of getting the right test, you might do well to learn how to do a suprapubic. This is the same study which is simply designed to show you the breakdown of how the urine cultures came out based on whether they were from a catheter or from a suprapubic, and based on the urinalysis results. We can avoid needless antibiotics if we maybe choose the right test. Another thing that is really important is knowing your hospital. Resistance patterns of organisms vary based on hospital, vary based on region and area of the world. Therefore, if you want to ensure that you are using the right antibiotic, ask your hospital for their antibiotogram. This can help you in determining appropriate therapy when you need it. The right thing to do is to narrow the spectrum. Narrowing the spectrum of coverage and tailoring it to one organism is far better than using a sledgehammer to kill the one organism. When you've got multiple organism types and you use broad spectrum antibiotics, the likelihood that one of those organisms will develop resistance is higher. Using a narrow spectrum, once you identify the organism, helps to avoid broad antimicrobial resistance to some of our most powerful drugs. It is the use of broad spectrum antibiotics and not tailoring them down to the right narrow spectrum for an individual type of bacteria that has led to the emergence of things like MRSA, VRE, and multi-drug resistant E. coli as well. If you're looking for a quote, one of the things that you need to think about when you're talking about dosing is that generally prescribers should always use the higher end of the recommended dose range for a specific infection to treat children with normal kidney and liver function. In other words, if you're going to choose a drug, hit the organism hard. Don't use a low dose that they might develop resistance to. Another thing that you need to think about, just like this very short golf course, is always wanting to use the shortest course possible. In other words, give the bacteria the least amount of exposure at the right dose to kill it. And another quote is, why do we treat infections for 7 days? That's how long a week is. That really is what it comes down to, if you ever wondered why we treat most often for 1 to 2 weeks. Don't just take my word for it. There is research on this, including this study from 1998 that occurred in France, looking at strep pneumoniae resistance using long dosage and long treatment durations versus high dosage, shorter durations. And what you can see from the table is that the adjusted risk in terms of developing beta-lactam resistance was high, almost 6 to 7-fold with low dosage. And if you used a long duration of treatment, it was about almost 4 times as high, long course being greater than 5 days. We need to be careful in using short courses at high dose if we really want to minimize the opportunity for bacteria to develop such resistance. As Benjamin Franklin is thought to have said, an ounce of prevention is worth a pound of cure. What I mean, of course, by that is vaccination. If you're like our center here in Manitoba, Canada, we have a recommended vaccine schedule for children. Vaccination against common organisms is the best way to prevent disease. If we can prevent those organisms from taking hold, we can prevent the emergence of antimicrobial resistance. Depending on where you are in the world, we all have a job to do in trying to deal with vaccine hesitancy. If we fail to deal with vaccine hesitancy and we begin to see emergence of organisms that cause serious to lethal disease, we may find ourselves in the challenging position of no longer having antibiotics to treat established disease. And that is a place that no one wants to be. In conclusion, try your best to treat true infections. The key there is identifying what is a true infection. If you're going to treat, make sure to use the right antibiotic at the right dose for the shortest amount of time. Thirdly, know your local resistance patterns and choose your antibiotics based on your antibiograms. Remember, saying a patient was sick when you drew the cultures and saying that is the reason for continuing antibiotics really isn't a great argument. And finally, we all need to do our part as pediatricians and neonatologists and promote vaccination. Thank you.
Thank you for Michael. And we have the time of some question. Hi, Narvy. Hello, welcome you again. Welcome you again. Thank you for your very interesting talk. Now we have some questions. May I have my question, if you don't mind. Is there any way for the precision medicine to work for antibiotic in the neonatal care unit? I'm talking how regarding a selection of drug dose, duration, or whatever, depending on the manufacturer, which I mean, it would be specifically to or personal to a patient.
You know, that's a fascinating question. I think, you know, in part we do try to practice precision medicine in the sense of, you know, knowing, you know, in more broad terms, knowing the antibiotic susceptibility patterns is not precision, that's more general, but identifying susceptibilities ideally within 24 to 48 hours, and then tailoring the antibiotic is certainly precision. But I think what you're really getting at is we know that antibiotic effectiveness is not just about the antibiotic, it's about the host as well, and how the host, their innate immunity enacts or interacts with or augments the effect of the antibiotic. So I think you're onto something in the sense of, you know, I just actually, you know, was reading about the idea of doing genomics or genetic analysis on newborns for everybody. and then getting an idea of who has stronger immune systems, who has weaker immune systems, who has mutations that make them more susceptible to gram-negative. So I think that our future is going to look something like that, where, to your point, somebody who has a predisposition to infection, you probably would go longer. And somebody who has a robust immune system, you might go shorter. So I think you're hinting at something that is coming, but not quite ready yet.
Yeah, I see. I think maybe the artificial intelligence will be a helping hand for this as well, and make it faster.
Yeah,
Thank you.
I think you're right. I just attended a workshop on artificial intelligence, and I just wanted to say, I think we're not there yet, but I do think that, as I said, just a quick comment on that. As I said in the workshop, there's so many different things, so many data points that we need to remember. And certainly AI will have a lot of promise towards being able to handle far more data than we can currently handle.
Thank you.
Dr. Rida, may I ask a question, please?
Please, Dr. Sameh.
Yes, please.
Go ahead.
Michael, thank you very much for your excellent presentation, but sometimes we have some organisms that are resistant. We have multi-drug resistant organisms most of the time in some of our units, like Klebsiella, like E. coli, like Acinetobacter. What would you do if you are facing? And sometimes also blood culture takes some longer time than, I know that in Canada it takes only 2 days. Here it takes more than 5 days or even 7 days. Mm-hmm. What do you do in these cases?
I think the general approach, regardless of whether you have MDRs or not, is you start broad. Because of course you're 100% correct. We don't. A baby doesn't, at the time of blood culture draw, have a stamp on their forehead that says this is a VRE. We don't know that. So I think, again, you have to go back to your antibiogram and know your hospital antibiogram, because if for example, that if it looks like enterococcus, 50% of your patients will be vancomycin resistant, then you're going to have to start something far broader. The other thing that I certainly would endorse, I am, much like many of the people here, likely a neonatologist or a pediatrician. We work as a team. And certainly if you work in a region where there is broad resistance, multi-drug resistance, I would encourage you to sit down with the ID colleagues, your infectious disease colleagues, and work out, a written pathway that says, if it looks like a gram-positive organism, this is the initial choice of antibiotic on the gram stain. If it looks like it's a gram-negative, this is our initial, choice on the, for antibiotic coverage. But with using the principles of that I've certainly talked about, what you would want to do is, as soon as you know that you can narrow that spectrum down, it's our obligation as healthcare practitioners to do so, because the longer we expose not just that bacteria, but thousands, millions, billions of other bacteria, but certainly other types of bacteria to these antibiotics, the more opportunity we give them to then develop resistance to even those, antibiotics that are still working.
Okay, thank you very much.
Dr. Sameh, may I have one question, please?
Go ahead, Dr. Azza.
Yeah. May I ask about the case that you have presented in the beginning? What was the progress of the case and how did you manage it? You said that you had only one culture and it didn't prove 100% that it's an infection. We need to have the signs, the risk factors. What were the risk factors for this baby apart from being just 750 grams?
Right. So truthfully, that was a fictitious case. I created a case for the purpose of the session, but the case though is representative. It was intentionally made in a certain way to be representative of something that we encounter all the time. I can tell you, locally, we used to draw just one blood culture. At the time of presentation, this was many years ago. We drew one, and one thing that we did, we've never published it, but one thing that we did was, whenever we would meet as a hospital, the hospital would identify that when infection control looked at our rate of infections, they always said it was lower than the rate of infections that we said. And it was because they required 2 cultures. We only required 1. So once we started requiring 2, we discovered, much like the paper that I shared with you, which is a legitimate paper, as opposed to fictitious case, we discovered that about 40 to 45% of the time, what we thought was a true infection turned out to be negative, meaning we had 1 positive blood culture, 1 negative blood culture. And, the quote that I gave about, you should have seen the baby, they were really sick. That was a colleague of mine, Dr. Beyer, who is retired, except he was the one who taught me that, where he pointed out, nobody's drawing blood cultures on babies that aren't sick. So you're always going to hear that excuse to say, oh, we should continue antibiotics because they were really sick. I don't believe the negative culture. But we've generally moved here towards a position of only treating those babies who truly have a positive blood culture. There are exceptions. There's 2 positive blood cultures. We will, on occasion, if there's 1 positive, 1 negative, if it's a known pathogen, like if it's an E. coli, enterococcus, we of course will treat that. But for coagulase negative staphylococcus, you would really have to be critically ill and getting worse for somebody to say they wanted to continue antibiotics.
Yeah. Okay. Thank you.
Thanks. Okay, thank you for Narvy. And now we move to Professor Safa to introduce the next speaker.
Thank you, Dr. Samah and Dr. Yasser, for organizing this very elegant webinar, and for the sustainability. This is the 3rd year for this webinar.
Dr. Safa, this is the 5th year.
5th year.
Yes,
Yeah.
6, but okay. Okay, but every year there is a new important
Thank you very much.
And I would like also to Dr. Imam Badran, Dr. Alam Dr. Muhammad Rida Basyunian, Dr. Azza Zohdi, Dr. Yasmin Mansi for sharing as a moderator in this panel. I have the honor to introduce the next speaker, Professor Ruben Alvero. He's going to talk about respiratory support stewardship in NICU. As we know, Dr. Ruben Alvero is the medical director of the Neonatal Sleep Laboratory at the Health Science Center, a former division chief and associate professor of pediatric at University of Manitoba. Dr. Alvero's neonatal professional activities have encompassed education, research, administration, and clinical care. His main research focus has been on the control of breathing and respiratory care in the fetus and neonate. He has also collaborated in many local and international randomized clinical trials in the area of respiratory medicine and family integrated care in NICU. He has published over 200 original papers, abstracts, review articles, and book chapters, presented over 100 lectures in national and international conferences and seminars. Dr. Ruben Alvero is going to talk to us in about 25 minutes. Then we will have questions.